Brilliant, thank you. And hopefully everybody can see these. And just to let you know, we have started recording now, so we will be recording this session and then sharing it on the Primary Care One website afterwards for people to access who haven't made it today, or if you want to refer back to it. So Prynhawn pawb croeso and welcome today to this session all around criminal justice, public health and primary care in Wales. And I'm thrilled to have so many of you on the call today, and also for all our speakers who are going to share some of their experiences and expertise within this area. So really hoping today for the start of a journey and thinking about collaboration going forwards, looking at continuity across health and justice, and the different opportunities that we have going forwards. So if we just go to the next slide, I'll just give a brief outline of the agenda today. So first of all, we'll have Helen Erswell, consultant in public health from Public Health Wales, and she'll be providing an overview about the public health perspective on criminal justice. And then we'll hear from Steph Perrett, also from Public Health Wales, who's a nurse consultant, and she'll talk about the health needs for people in the criminal justice system and a bit more about some of the work she's been doing around cardiovascular disease and other health needs. Then we'll hear from some colleagues from prison healthcare. So Tasha and Ree from HMP Park will provide a bit of an overview from their perspective about providing healthcare within the prison setting. And then a colleague from Swansea University, Ella Rabaiotti, will talk about then in terms of the probation setting and some of the research and findings that she's learnt about health and barriers to accessing healthcare. Finally, then I will go on to talk about some guidance that we're proposing around continuity of care and thinking about how we can optimise health for people in the criminal justice system across Wales. So just to highlight here today, so we do have the slides in English, but if you would like a Welsh version, then they have been uploaded to the Primary Care One website, and we'll pop a link in the chat as well. So if anyone would like to access those slides in Welsh, then they are available for you today. So without further ado, we'd like to introduce our first speaker here today, who's Helen Erswell, and she's going to talk about the public health approach.
Hi everyone, good afternoon. I'm Helen Erswell. I'm a consultant in public health. I work in the health improvement team within Public Health Wales, and I lead on drugs, alcohol and gambling. I think I'm been asked to come here today and talk about the criminal justice system and public health approaches, because previously I was the health and justice lead for the South West England for UK HSA, and prior to that, my first job really in public health many years ago was as a drug worker in HMP Belmarsh. I managed drug services in Belmarsh prison, so I've worked within a prison, but I've also worked in lots of the criminal justice agencies, working in police stations and prisons and youth offending teams and the probation service. So I've been working in and around prisons and the wider criminal justice system for a long time. Okay. So I've got a bit of a hypothesis. So I was thinking about what is a public health approach to the criminal justice system, and I was thinking two things really, one of which is that it's a setting in which we can deliver services, public health response, whether that's the health protection response when there's outbreaks, whether we're talking about using it as a setting to do kind of cardiovascular screening, or we do work with people on probation or children in the youth offending team and that system. But it's also a partnership I'm going to propose that goes beyond health, and that we've got some shared outcomes with the criminal justice system, those of us who are working in health and public health, and that the shared outcomes will subsequently benefit health. So we can do the work within the criminal justice system, but by making a good partnership with our colleagues in the criminal justice system, we can have some impact on things like offending behaviour and some of the drivers of why people end up within the criminal justice system. And that also, I think, it's really important that we understand that this in itself will benefit health. A reduction in crime will benefit the person who has previously been committing crime, but it benefits our communities in a really powerful way when people are living in communities which are less likely to be impacted by crime. So if we can get this right, I think there's a potential for a win-win. Now, I'm just going to pause slightly from my slide and say, I've been working, as I said, around the criminal justice system for a long time, and I think I'm cautiously optimistic right now because we have a new prisons minister in the UK government who is a prison reformer, and from some of the interviews that I heard over the weekend, I don't think that he disagrees with this as a prospect either, that there's some partnership work to be done that can benefit people in prison, and that will indeed benefit the wider community and our health. So cautiously optimistic about what that could mean. But first, I want to just talk about what is public health, and I apologise if this is things that everybody already knows, but I think I often hear people say to me, well, this is a public health issue, and is this a public health issue? And I think it's important. Why don't we just, what is a public health issue, and then we can fit any issue around those definitions. So you've probably seen this, you probably already know science and art of promoting, protecting health and well-being, preventing ill health and prolonging life by the organised efforts of society. And I think there's some important points here, which is it's both protecting and promoting. So that is our health protection responses, but it's also about promoting health and promoting well-being as an asset. And it's also about the organised efforts of society. And again, I believe really strongly that the criminal justice system is often just slightly outside of the systems that we work in health, whereas actually that is part of our society. Criminal justice is part of our society. And so any organisation will have to include that system. And just a very, very brief overview of what is the criminal justice system, because it's actually quite broad and it's quite complex. It sits on two different UK government departments. We've got the Department of Justice and we have the Home Office. Home Office deals with the police, Justice deals with courts and prisons, but you can see there's many facets, and it's not like a pathway that's, you easily go from one bit to another. People can be interacting with a whole range of different bits of the criminal justice system, and this is just a flavour. We've got prevention stuff that's going on, diversion schemes, voluntary sector working quite heavily there. There's a youth justice system, violence prevention units, we've got police, which is kind of quite complex in itself, Home Office, HMPPS, which is probation as well as prison, the courts, there's the inspectorates, and also victim support. So it's important to think about the criminal justice system as a whole system, not just prisons. So going back to what makes something a public health problem. Now, this is not an exhaustive list. I've done some reading on this, and this is some of the things I think comes out strongly in the literature, which is that something's a public health problem when it affects people at scale. And so we've got 85,000 people currently in prison, and I think there are even more people affected by, I'm just trying to find my notes because I wrote down, so we have 95,000 people in the UK, that's 85,000 in England and Wales. We've got about 250,000 people in the country, the UK, on probation. About 300,000 children are affected by parental imprisonment every year. There's 8.67 million criminal offences occurred in 2023. So I think we can say that this is a problem at scale. It's a lot of people are affected, and also how it's affected. So it's not a small issue for those people who have contact with the criminal justice system, whether it's people who are going to prison, people who are sentenced, or people who are victims of crime. So it's a huge number of people. So I think we can tick off scale. Unequal in risk factors, prevalence, and outcomes. I don't think I can think of anywhere else where inequality permeates so massively through an issue as it does in the criminal justice system, both in terms of perpetrators and victims. You are way more likely to be a victim of crime if you live in a poor area, and you are, exponentially more likely to go to prison if you belong to some of our inclusion, what we might call inclusion health groups. So it's absolutely unequal in its scale, and whenever people actually find their way into a prison, or they're always struck by just the inequality that people have suffered through a lifetime that finds themselves in custody. And the other thing that's important is when we're defining a public health problem is that can it be prevented? And I think it absolutely can. We know it can because we don't have these issues. You know, there's different levels of imprisonment, different levels of crime in different countries. So we know that different approaches can reduce crime, can reduce imprisonment, can reduce your risks, and that there are early intervention approaches, upstream approaches that we can employ that can prevent much of this. So I think on this basis, the criminal justice system represents a opportunity for public health because it represents a public health issue. And Steph is going to talk a lot more about some of the issues within the prison, within custody, and the people who are involved in the criminal justice system. So we know that there will be high rates of mental health problems and drug problems and alcohol problems and so on. So I'm not going to go into too much detail there. And so this, again, is what we're talking about. What is a public health problem and public health approaches? These are some of the underpinning features of a public health approach. So we have surveillance, that's getting good data, understanding what's happening, understanding trends. That's really important. We need to have an assessment of needs. So what is no good just having an anecdote. We need to know exactly what the need is of this population. And a whole systems approach. It couldn't be more important in a criminal justice system than to use that whole systems approach and using the perspectives of a criminal justice system and integrating that with our public health approaches, because that's where you can find some synergy for work. Evidence-based, always, and where we don't have an evidence base, we try to generate it by evaluating what we're doing and looking at our outcomes, which takes me to my next point, and outcome focused. So it's not good enough just to do stuff because we like it. We have to do something that actually achieves its outcome. Whole population approaches, that's really difficult because we are talking about subpopulation, but actually there are things that we can do that we know will work across a whole population, whether that's right back in prevention, kind of youth justice system stuff, or whether that's within a prison or for people on probation. Advocacy, I was talking to someone about this morning, a really important part. And when you work in groups which are often seldom seen or are not always are kind of stigmatized groups, and I think prisons definitely are those groups, part of our job in public health is to advocate for them and advocate for the health of that population. We want to target the most affected whilst thinking about the broad population, which is a balancing act that we do in public health the whole time. And an important feature, I think, of a public health approach is that it's not just about individuals, it's about our society, culture, power and economics. And I think that, again, in prisons, that there are decisions that are made amongst people within the criminal justice system and the lifetimes that people have spent in inequality that leads us to the situation that we're in. And so a public health approach has to understand and unpick some of those things if we want to achieve outcomes. Just lots of experience of working within prisons, and I think, and not just, I apologise, I keep saying prisons, but it's actually the criminal justice system generally. And I think there's some really important key areas if you're in public health or health, how you interface within criminal justice. It's really important to think about some very criminal justice specific context, and that is security. And that's around making the estate safe and the people in the estate safe, really important. And it will be the priority of a criminal justice system will be security, 100%. And I think any approaches that we take within a prison has to, or a criminal justice system has to, really understand the security implications of what you do. And it adds a level of complexity, which is not something I necessarily come across in other settings in the same way. Complexity. One thing that's brilliant about working in the criminal justice system is how the people who work in it are really able to manage this complexity, because they're doing a kind of a million very difficult things on a shoestring all at once. But there is a lot of complexity. We want to offer services for people. We want to be able to help improve people's lives. But there is a lot of complexity in terms of the individuals involved who are very complex, and then the settings are very complex. And it's really important to take that time to understand your stakeholders and understand what that complexity is for whatever setting. And again, it will change. My first prison I ever went to was HMP Belmarsh, which is one of the most secure prisons in the country. And I've always been told since then by governors that I need to kind of understand that not all prisons are like that, which is true. The security levels there are different to anywhere else, and it just shows the complexity of the estate means that people will move around from prison to prison or back to the community, and varying different types of security and complexity in those settings, and you have to understand each one of them because they'll be different. And then finally, risk. There's an awful lot of risk that's held by people, our colleagues in working in courts, probation, prisons and so on. And the risk is around the individuals and their risk factors and some of the wider risks to society. And again, all approaches have to kind of manage the risk and ask for help on the risk, and the risk assessments need to be really, really well thought through. But I'm a big advocate for working within the criminal justice system because this is a population with a really high health need, and Steph will go into some of those details. But it's an aging population, people with high levels of drug and alcohol use, lots of mental health, plus people with your general health problems are there. And so there is this high health need. And I think if we think of health as an asset for an individual, something that we can really do is help increase the value of that asset to people, because that's going to be some of the life-changing things. When people leave the criminal justice system, which is what we hope they do, then that asset is part of what will help them rebuild their lives and live more lives where they don't find themselves back in interacting with the criminal justice system. But I'd also say health is an asset for communities, and people in the criminal justice system are coming from communities which are already unfairly impacted by inequality. So we want to build up our community assets, and some of that is what we can do by improving the health of people who are already in the criminal justice system. And also some of these health issues are massive factors in offending behaviour. So particularly mental health and substance use is a huge factor. So there's some opportunities improving health will improve other outcomes. And the shared risk factors, the risk factors for poor health, we know all about ACEs and the impact that has on health throughout our life course. They're the risk factors for offending, and that's what gets people in prison. So there's an element which is that we want the health for its own sake, but actually health will be a driver to help really change people's lives, and that will have an exponential impact. That's me. I've whistled through that very quickly.
Brilliant. Thank you very much, Helen, for sharing that, and lots of things to think about going forwards. What we'll do now is we'll move on to the next presentation, but then at the end, if there are any questions for Helen, or if you want to pop anything in the chat, then please do. And we will move on to the next presentation now from Steph.
Lovely, thanks Penny, and thanks Helen for that great introduction. I share your optimism in moving forward, and I absolutely agree that this is an area that we can do better at and make some really good health gains in this area. So it's really good to have, the opportunity to come together today and think these things through a little bit. So if I can have the next slide, please. Lovely. So Helen's already given a really good overview of sort of criminal justice, what that means and some of the definitions. I've got just 10 minutes today to talk a little bit about the health needs. It's a massive area and the health needs are really great. So I could have, I'm going to make it really kind of broad brush, I suppose. But just so we understand the sort of criminal justice populations we're talking about in Wales, because I think most of us on this webinar will be from Wales. So these are the populations we're talking about. So I've just included there the sort of numbers that we're looking at in Wales. So within our prisons, we're looking at about holding 5,500 people at any one time in our prisons, and then a significant number of people on probation. Some of those will also be counted in the prisons, and you can see from the also covering the different areas of Wales. So it's a big population, and again, this is sort of repeating a bit of what Helen said, that we're talking today about criminal justice as a sort of bespoke population, but these are individuals that are part of our community. They're not, I think sometimes people might perceive that once somebody's in prison, they're kind of separate, they're there for a very long time, and they're not necessarily considered a part of the community. But our criminal justice populations are very much part of our community. As Helen's already said, they suffer a massive amount of inequalities, and we see that a large number of these populations do come from some of the highest areas of deprivation. I quite like this diagram. It was one I pinched from an UXA document, and ignore the sort of coloured arrows, because the coloured arrows are at the time used to demonstrate which services and things were running during COVID and which had stopped. But I quite like it because it does show the movement of people, and there is a vast amount of movement from the community into prison, between prisons, to courts, to families, to the streets, to homes, to jobs, to hospitals. So you name it. Helen's talked about all the various agencies that people might interact with along that journey. Custody services, courts, victim support, all of those things. So there's a lot of professional interactions, I suppose, and service interactions with people along that journey. And it's by no means one straight line of a journey. It's a complex journey. But these populations are part of our community. We improve their health, we improve the health of our community. There's community gains to be had there. If I can have the next slide, please. So the health needs of our criminal justice populations are vast, I think. We tend to see a higher prevalence of most conditions and of most risks compared to perhaps the general population. And I guess the main message from what I would say today is that the health needs of those in touch with the criminal justice services are generally multiple. They're very complex. They present acutely, they present as chronic, and when they do present, they often present late. And so I think it's not always easy to just see somebody and make a diagnosis, because the needs really are great and they're very, very complex. We've also got evidence to suggest that the populations are generally 10 years, particularly for prison populations, this is now generally about 10 years more physiologically aged than their chronological age. And I'll touch on that in some of the data in a moment. So just looking at, and again, this is really broad brush, but just looking at the sort of health needs that we see, and this is some data, this is some old data actually from Scotland, but I do quite like it because, again, it's quite broad brush, and I'd like to say things have changed since this data was published, but I'm not completely convinced it has. So you can see the amount of the increased likelihood of having problematic alcohol and drug misuse in these populations, increased level of smoking, as smoking levels of the general population are now reduced. I should have taken that out compared to this slide now, but certainly we see higher levels of tobacco use in these populations still compared to the general populations. Things like dental problems, dental decay, 3 times as much as you'd see in the rest of society. Bloodborne viruses, we see our levels for hepatitis C in Wales tend to stay at around 10% positivity for those that we screen. And things like asthma, again, much higher rates of asthma than we would see in the general population. The next slide. And I'll touch on, I mentioned about people in prison being 10 years more aged than their chronological age would suggest, and certainly the data does back that up, and this supports the reason why we offer some things earlier to people. For instance, the flu vaccine, we would offer that to people earlier in prison than we would make that offer to those in the community. So this is data from and we went in and we did some clinical risk assessments on about 300 men, just under 300 men there, to look at their cardiovascular health. And you can see the levels of high cholesterol, of increased blood pressure, unhealthy weight. And then when we calculated all of that and turned it into a heart age, you can see in the bit on the right hand side of the screen what that heart age looks like. So overall, that heart age being about 7.5 years more ages than the chronological age, and certainly that difference increased with age, as you can see there, for those who were in the 40 to 49 age bracket, and for those who were 50 certainly had their heart age was nearly 10 years more aged than their chronological age. So it just shows how at risk they are. And then when we look at mortality in these populations, and this is mortality, just some causes of death that we've pulled and analysed from probation data in Wales. And this isn't present, this is from probation. And you can see the causes of death that we tend to see in these groups. You can see quite a clear difference there by age, actually. So if you look at that second table there, you can see much higher rates of causes of death by accidental drug-related deaths for those in the 18 to 49 years of age. And if you look at the age 50 and over, you will see higher rates of diseases of the circulatory system, disease of the respiratory system, and malignant neoplasms, which would be our cancers. Now, some of that, of course, you would expect to see those changes by age. Generally, for a lot of cancers and things, that risk increases with age. But I think a lot of these are presenting late, and what this data does show us is that the prevention needs to be brought in and strengthened, and some of these may well, by working with the 18 to 49 years age group, we may prevent some of these causes of mortality, or at least delay them. So that's just some of the data on mortality. Can I have the next slide, please? And the thing, I suppose, that brilliant, if you can just put one more arrow, that's brilliant, thank you. And the other challenge that we have is the design of our services, I suppose, and good to think about this today. We're sort of thinking about primary care, but what we do see in the criminal justice populations is low usage of our traditional community primary care services. Many of these populations access prison healthcare, and then when they're out in the community will access emergency services. So we see high usage of emergency services and generally quite a high rate of hospital admissions as well. We did some data from probation, and you can see there that a third of respondents, this was in the south west area of Wales, had attended A&E at least once in the last year, with 9% attending on 3. So our services aren't well designed to meet the needs of a population that is in some ways so mobile through the estate, in and out of prison, and through different services all of the time. I can have the next slide, please. So I'll just this slide and then a few recommendations, and then I'll finish, and I guess we can have some discussion at the end of the webinar. I suppose what the main conclusions I want to draw is, as I've said before, the health needs of these populations are multiple, they're complex, and they tend to present late. They do not routinely access the services that we provide. So I think that's really a challenge on us, and what our services look like, how easy they are to access. And absolutely, as Helen said in her presentation, by improving the health of these populations, we will reap massive benefits. And I absolutely agree that health is an asset. I can have the final slide, thank you. So I think the learning from this, really, prevention needs to be offered as early as possible. And we should definitely take, I'd say, I put here a multi-pathogen approach to screening. But when we have interactions with some of these populations, they may present with one thing, but they will undoubtedly have other complex issues behind that. So we need to be offering as much support as we can in that opportunity that we have when we do see them. So rather than taking a single disease approach, we need to offer as much as we can. Almost in a sort of one-stop shop, I think would be really helpful for these populations. Again, our services need to be delivered as closely as we can to these populations to re-look at how accessible they are. And there's absolutely, I think, Helen's talked a lot already about the partnership agency, and I would absolutely, partnership working, and I would absolutely echo that really we need to work more closely with other agencies. And I don't just mean sort of within our health boards and between health agencies, but really partnering with other agencies. In that map I showed at the beginning, the movements that people have, they're going to all of these places, to courts, to different support services, and how can we capitalise on those interactions and provide health opportunities at those pinch points as they move around the system. And I think that's it from this presentation. Thanks, Penny.
Brilliant, thank you very much, Steph. And And what we'll do now is we'll move on to hear from Natasha and from Rhiannon, who are going to give us a prison healthcare perspective. So I'll hand over to you.
Oh, thanks, Penelope. My name's Natasha. I'm one of the lead nurses at H&B Park, covering learning disability services.
My name's Rhi. I'm one of the lead mental health nurses for the primary care team. We're just going to talk to you today about H&B Park. We're a Cat B prison that's privately run by G4S. There's 1,804 prisoners with us, and they're all various ages. There's a small nursing team. There's literally 25 of us in post. We're varied. There's learning disabilities, registered general nurses, mental health nurses, and healthcare assistants.
Yeah, we're a working prison as well, so obviously all prisoners are expected to engage in education and work, and we kind of make sure everyone's got access to like meaningful activities. So we'll just go on to a little bit about what we deliver. So if we can move to the next slide, please. Thank you. So we've got a big multidisciplinary team, and that consists of lots of variety of health professionals. We've got social services that commission social care packages to patients. And we obviously look after patients from age 15 all the way up to, very old 80, 90-year-olds that have got a variety of different healthcare needs. So delivering packages of care, they could have 4 social call cares a day. We also have got like doctors on site, general practitioners, your chiropody dental team,
Physiotherapists.
Yeah, and we also have a pharmacy team on board as well, and lots of other people that come in, so for sexual health. We try to mirror community settings, so we're nurse-led service, and try and ensure, sorry, are we able just to go back? Thank you. We also manage long-term chronic health conditions, so looking at things like outbreak management, things obviously like with COVID, with Public Health Wales, TB, we did a massive outbreak with TB a few years back.
AAA screenings, we do retinopathy clinics, we've got BBVs, health promotions, bowel screenings, and quite a lot of our gentlemen, they don't actively seek treatment in the communities when they come into custody. Quite often then we pick up some of their appointments and follow through any physical or mental health appointments, ensure their needs are met whilst they're here with us.
We respond to medical emergencies. We've got 2 different medical emergency responses, code red and code blue. So they're called by operational staff if there's any emergencies, and we would respond to them.
So we've got like code red, where it can be anything from like an open fracture or severe blood loss, and then we've got code blue then where there's any airway compromises or seizure activity. And
drug related.
Yeah, some of the incidents can be drug related, vary quite dramatically in severity.
Yeah, if we can move to the next slide, please. We've also, like I mentioned, we've got a pharmacy department, and we employ pharmacy technicians that help with medication rounds and delivering medication to patients. You can imagine there's quite a lot of patients here, and there's a lot of medication that gets given out on a daily basis. We probably, deliver around 1,000 maybe meds a day, including
especially for the new arrivals. We have like new transfers who come in. So on our house block where we have new transfers in, we give out about 80 medications in the morning, and then again same in the afternoon. So we have quite a lot of gentlemen that are prescribed medication, don't we?
Yeah. Obviously substance misuse, doing substance misuse clinics. Obviously we've got a high population, and a lot of those engage in illicit substances.
Quite often we have patients who are under the influence of like spice. We've got a new trend of nitazines in at the minute, so the drug of choice kind of varies, doesn't it, over time, but spice remains quite popular.
Yeah. And if you want to talk about mental health support.
So I'm one of the lead mental health nurses. I oversee the safer custody and segregation unit. So it's a small 15-bedded unit where they're primarily housed because they're in crisis. When I first started about 9 years ago, it was kind of like a period of respite for patients, but now we seem to be transferring people more to a secure unit. So in June, we transferred 7 patients to a secure hospital. So the the severity of people's mental state deteriorating is a lot more prevalent now, and there's a lot more complexities. There can be some delays in terms of transferring patients to hospital settings, so we're managing them whilst in crisis with a poor mental state in custody, which can be really difficult.
Yeah, and I think it's important to kind of say that although we've got that separate unit, that's managed by operational staffing, so it's not a healthcare-led unit.
There's only a small team of nursing staff, so on one working day there may only be 1 or 2 registered mental health nurses, so we're not constantly in that area, although we do try to oversee it.
With regards to learning disability support, we've got a specialist unit for people with learning disabilities, autism, neurodiversity, brain injury. So it's just kind of a unit with additional supports. We've got SEN teachers and support workers that help kind of deliver support to people who are more complex or need that additional support whilst in custody. And with that, we do like weekly MDTs to discuss referrals, and then we support them through training, behavioural management plans. And he's also recently appointed a prison neurodiversity manager that's working well with patients down there. Can we move to the next slide, please? So obviously we know, and I think looking at the presentations before, that prisoners experience significant health inequalities compared to that of the general population, and that's kind of due to a number of factors, which we'll discuss a little bit later on. But we know they should have the equitable healthcare as they would in the community, that patients ensure they have access to advocacy should they need that while they're here. We need to ensure that all patients feel safe and secure whilst they're with us, and that they all feel respected, and that we're not judgmental to their crimes. If we can move on, please. So we're looking at some of the barriers and challenges to prison healthcare. So like we said, we know people have significant health inequalities. So and we're underfunded really. We've got lack of resources. We don't have primary OT, psychiatry, psychology, and that's for both mental health and learning disability services.
So we heavily rely on the secondary care team for patients that meet the criteria to be assessed by a psychiatrist. So yeah, they're also a small team.
Yeah, and like we said, about section into hospital. Obviously, there's a length of time awaiting beds. Historically, we never had as many, mentally unwell patients, and that's kind of, as the years have gone on, that's got more prevalent, and therefore we're waiting longer periods of time for beds for people to go into hospital. We've got obviously low staffing numbers in both health and operational, and that kind of has a massive impact. So when we do employ staff, it takes a long time to vet people, and then therefore we're using agency nurses, but they don't have keys. So although there's a body here, they're not able to move around the prison. I
think as well, like it's a large establishment. People think that we're just in a small little area, but we're a big place.
With regards to operational staffing as well, that if their staffing levels kind of leads to impacts then. So it could be that there's wing lockdowns because they haven't got staff to monitor them, but that increases risk of self-harm, mental health issues, behavioural issues, which then impacts us because we end up having to go out to those patients.
Sometimes if there's like disruptions within the establishment, the operational staff will call what's called a gate freeze. So that means that no operational staff are to leave the establishment. They have to stay on site and manage the incident, and then that can impact patients then that are waiting to go out for standard routine appointments externally. So those appointments need to be rescheduled, and obviously it's wasting slots, appointments that could be used by other people because the operational staff are unable to meet those appointments.
Yeah, I think hospital escorts is a big thing. We have, the capacity that we've got here, and we only have 6 slots a day, 3 in the morning, 3 in the afternoon, and that's for routine appointments, which are always fully booked. And then we've also got, other people who have just come in and maybe have got a hospital appointment that maybe it can't be facilitated because the slots have gone, and then that's not including your additional A&Es. So if we've got A&Es that need to go out for an X-ray, for a acute fracture, then that kind of gets delayed if there's no operational staff, and they might not go out for days after we've initially raised that.
I think moving on to then like the security and the drugs. So we have quite a lot of, there's been quite a lot of input on social media and in the media in general about the recent illicit substance misuse and how severe they've been to people, caused or have impacted the health of people significantly, where they've spent long periods of time in hospital receiving treatment and then come back to us. There's been quite a lot of incidents where patients are heavily under the influence of spice, and due to the risk of CNS depression, their prescribed medication will be considered by prescribers, and then they have to be reviewed prior to restarting the medication. And that can also impact the patient, because although he may have been on an illicit substance misuse, let's say on the weekend, and come the Monday he wants to be prescribed that medication, and it can be difficult then, you know, to ensure that there's no other kind of illicit substances being used and mixing with the prescribed medications. They become quite frustrated and don't understand the risks sometimes and how detrimental it can be, you know, mixing the two together. So that can be quite difficult, can't it, having those conversations with them.
Also, you know, conflict with operational staff and attitudes of operational staff as well can be a barrier. You know, there's some staff members that kind of treat prisoners as prisoners and maybe don't see them as a person and hasn't got that empathy.
Yeah, it's difficult for us to kind of, you know, because we come in from a caring perspective and we want what's best for the patient, and trying to say, you know, the severity of the injuries or any like chronic or acute health concerns, and the fact that they need to attend hospital. Sometimes operational staff will overrule us and say that they don't have the facilities or the staff in to manage the escort, so the nurse and staff will have to maintain medical observations for a period of time prior to them being discharged to hospital.
Yeah, so it can be difficult. There's also you know, lack of continuity of care. I know that's been mentioned in previous. You know, we've got people that come in, they're being released, they got no housing or address to go to, therefore there's no continuity then with any hospital appointments that are outstanding. You know, referrals to, if we need to refer to community mental health team, but we don't know what area they're going to. So there's lots of things with the continuity of care. You know, transferring between establishments, what we try and do is ensure that if they're moving and they've got an appointment, we will obviously inform the next establishment that they've got an appointment upcoming, and making sure that there's that continuity there. But obviously we know there's lack of engagement with the client group that we work with on times, and you know, they don't always follow up their health appointments when they're being released. And then we come to environmental barriers, which is a massive one in the prison. People spend long periods of time in isolation, which doesn't help mental health, self-harm. We have healthcare runners, so we've got quite a small healthcare department, and I think as you know, people having more chronic illnesses, and we've got more services coming in now. We've been adopted by the NHS. You know, we haven't got very much clinic space or clinical rooms, and then we're relying on operational staff to go and collect the patients to come up to healthcare, and that can kind of bring challenges in itself where people don't come up, and then the prisoners say, oh, we didn't know we had an appointment, and then the runners telling you they've refused. So it's kind of that's difficult.
A lot of time,
yeah,
communication.
There's lack of appropriate cells for like older populations. So we've got quite an older population, especially on X block, where we need hoist people and people in wheelchairs, and there's not room in cells to be able to do that. You know, to have that equipment. And then, like I said, lack of clinical space. Not enough computers, not enough clinical space for people to come in and complete clinics. If we can move to the next slide, please. So what we try and do to overcome some of these barriers we've discussed is look at person-centered nursing. We use behavioural management plans for patients who, you know, may be causing some issues on the wing, some behavioural issues. We do lots of MDT working with a wide variety of healthcare professionals, but also operational staff, and do some training with them. I know, like down on the Canice unit, that's the learning disability unit, we do training with staff. Just, you know, it could be individual for a patient, or it could just kind of be a generic training session, just so they are kind of aware of how to manage people.
And I think since going across to the NHS as well, it's been nice. We've had a lady come in from the university today and have a look around the prison, so people can get a feel for it and understand that it's not as scary or as awful as it's made out to be on the TV. You know, it is. We've got a lovely team and we all work quite hard, and it's trying to build those relationships with people in the community so they can come in and have a look for themselves and hopefully agree.
Yeah, and we ensure kind of effective handovers and good communication between establishments, and like I said, trying to build that up for people when people are being released to make sure that there's that continuity of care. We also have ALPs, so there's assisted living plans that, you know, can be opened with patients' consent when they come into the establishment, and that's kind of just to make officers maybe aware that that person's epileptic, and that, you know, to notify healthcare and call a code if they have a seizure, or it could be that they've got you know, chronic
mobility problems, and they struggle with some of the landings have 3 flights of stairs, so perhaps some of the patients will need a ground floor cell because they'll be unable to manage with the 3 flights of stairs. So that is a prison document that basically just gives an overview of the person's holistic needs and anything that can be addressed operationally as well as health to ensure that the patient gets what they need.
We also kind of take treatment to patients as well. So although, like I said, we've got, you know, small clinic spaces and you know, there's not enough, so we go out to the wings and we treat patients.
Yeah, in the sense that we mirror the community, we go out to their homes, we visit their cells and assess patients in the state on the wing, because we have limited capacity up in healthcare, so we try and see people in their cells on the wings as much as possible.
Yeah, and there's also, we also do telephone clinics. That was adopted kind of as COVID came in, so we've got telephones that we can contact patients in their cell via their phone, so that is good to kind of do medication reviews, or just kind of, you know, if you need further information from them rather than having to go out to their cells. And I know GP, they do some remote clinics as well. We've also got, we've had a health and needs assessment in the past, and I know we've got one upcoming where, you know, we're going to have people coming in just to have a look at kind of the environment and what kind of we need and how we can move forward. So that's something to look forward to.
And drug strategy meetings, they're held monthly. If we can go to the next slide.
I think that's it now. I think we're done. Thank you.
Brilliant, thank you so much. And it's really interesting to hear such a variety of what goes on within the prison healthcare settings. I'm sure some people on the call here today would be very interested and surprised to hear that so much does go on within settings. All sounds like fantastic work, so thank you so much. And I'll hand over now to Ella, who's from Swansea University.
Thanks, Penny, and good afternoon, everyone. My name's Ella Rabiotti. I'm a lecturer in criminology and a researcher here at School of Social Sciences in Swansea University. I worked in probation in Wales for 15 years, so I kind of bring this unique insight as to someone who's worked in probation and now kind of actively researching inclusion health and more broadly social inclusion for people in probation, particularly in Wales. So what I wanted to share with you today was a few of the studies that I've been working on recently, one in particular that's ongoing, and kind of my broader reflections really of people on probation as an inclusion health group. So if we just move on to the next slide. You know, what we've heard already, I guess, is there are big resourcing issues for health, and of course there's resourcing issues in the broader public sector too, and we know that there's big challenges in terms of prisons and prison capacity. So this is the context we're working in, and this particular participant in the study that I did last year, so a professional working in the sector, kind of recognise that people, you know, on probation are facing these health inequalities, you know, but also this context around resourcing, engagement, and actually how can we see this group as a priority? How can we ensure they get the healthcare that they need? Given the other demands on the system, and also because unfortunately sometimes this group is seen as an undeserving population. So how can we show that actually there's multiple benefits to working with this particular population group and reframing them really as an inclusion health group as part of this wider work to include people in society. So I am hopeful. I think it's already been mentioned with the changes in government, and I know that Peter has put in the chat about the work within health and justice coordinators in Wales. When I worked in probation, we didn't really think about health too much, and now certainly, HMPPS has got a new strategy, has employed health and justice coordinators, and there is work going on, as Steph mentioned as well, with Public Health Wales, and working more closely in terms of learning, evidence-based work in research, testing, and trying to innovate, I guess, to improve the landscape. So I am generally hopeful, despite some of these challenges and resourcing in particular. So what have I been doing so far? So if we move on, the first study that I did last year really built upon a lot of the work that Steph and colleagues had looked at in terms of understanding the landscape of people on probation and people in prison, what their needs were, what services were out there, and understanding that complexity really, and realizing that this particular group, as an inclusion health group, does face that stigma and that social exclusion, and that impacts really on how they journey through the system, and even whether they go and whether they even bother to access healthcare, whether they even go and engage with their doctor or nurses or pharmacies, etc. So moving on to the next slide, a few things that I did was, first of all, surveyed community services who were engaged with this particular population group, so beyond the public sector. And they were kind of the key informants who were engaging with people on probation and highlighted some of the issues that they were bringing forward to them, which was around service availability, waiting lists, but kind of this theme around mistrust coming out quite strongly in terms of whether they are then going to go on to access healthcare. And again, unsurprisingly, mental health and substance misuse related needs were really highlighted, particularly around depression, stress and anxiety. And the community-based services that were there generally in Wales providing kind of a general support, housing and employment support, and to a lesser extent substance misuse and health support, and they're more likely to perform of a kind of a signposting role rather than providing that support themselves. And what I will say is that I put in some freedom of information requests into HMPPS to look at some of the services they were commissioning, and there is an increase in services being commissioned around neurodiversity, but some of, for example, and looking at emotional support, but some of these things were targeted towards certain cohorts, women, for example. And of course, HMPPS doesn't have a role to put funding into health, yet they are making efforts and seeing the benefits, not least linked to reduced reoffending, as was mentioned right at the start. And I'm going to move on to talk to you a little bit about the current project I'm working on, because that, I think, has been more exciting because I've been able to come out and speak to health professionals, probation professionals, and in particular men on probation. We've focused looking at men on probation and their physical health needs, because my colleague and I, Dr. Gemma Morgan, felt that there was more research there around mental health and substance misuse, research particularly focusing on prisons, but less really looking at physical health needs of men in probation. And one of the professionals picking back up on this idea of stigma and this and mistrust, and what the results there are for that is that if people on probation are not being able to access this basic health care, the message that is being sent out is they don't feel worthy, and if they don't feel worthy, then they're not going to get these things checked out, they're not going to get that pain checked out, or they're going to then self-medicate, for example, or if they're having these barriers, they're going to kind of ignore, and hence the consequences that's been highlighted by Steph in terms of poor health. So what I did want to share with you a little bit is about some of my early findings. Moving on to the next slide. So this is a project particularly focused in Swansea Bay, but what I would say is that the participants included members of the approved premises and residents who lived there, not necessarily from Swansea Bay. So they will be describing their experiences from other parts of Wales. And equally, when they described their experiences of prison healthcare, they were not just talking about the local prisons, they were talking about different prisons that they've been in. So although we've focused our research in Swansea Bay, we're recognising that it's gone a bit beyond that. So we've spoken, as I say, to professionals and men on probation, and what I wanted to do just in the 5 minutes perhaps I've got left is focus on some of the early findings that we're still working through in terms of what the men on probation have told us. And I guess I should caveat this with saying, those that did complete our survey and speak to us, they're going to be your most engaged people. So of course we still didn't get to those most hardest to reach, or I know that that's not the phrase these days, but those most excluded people who perhaps aren't attending probation, aren't able to have a voice, and there is always more that we can do to find out what their experiences are. However, we were able to capture some of that. So there's 4 particular themes that I wanted to kind of delve into a little bit. And these won't be a surprise because some of these things have already been brought up already. So from the 33 participants that engaged with this, the men on probation, and the 17 who had these kind of longer interviews, these are the themes that are emerging so far. So the first one is around the continuity of care and transition into the community. Again, won't be a surprise. Steph mentioned there around dental decay being 3 times greater compared to the general population, and certainly around half of survey participants hadn't accessed dentistry for over 5 years or couldn't remember the last time they saw a dentist. And in contrast, those who had seen a dentist more recently were more likely to have accessed that dentistry in prison. But some of the problems there described by participants was the continuity of care in terms of their dental treatment. So a number of them were having work done to move to dentures, quite a lot of work done, and molds may have been taken, work may have been started, and then that handover into the community was not happening. So you had people who had part work done and not completed. In terms of general healthcare, of the people that we engaged with, actually 31 out of 33 people were registered with the GP, which is positive. 2 people unsure. They told us that it was quite easy to access healthcare in prison, of course, and much more difficult in arranging those GP appointments within the community, and that won't be a surprise. However, an outlier there was the residents that we spoke to at the approved premises, who had a much more improved experience in terms of accessing healthcare in the community, and that links to the support that they were receiving, that structured support, and the things that were already set up in place through the approved premises. So the second theme was this general idea of coping with life in the community, and I don't think we can underestimate the amount of digital barriers that people on probation will experience. My colleague Gemma Morgan has done work looking at problems around digital literacy, and from our survey, only 6% of participants were using online booking systems to access GPs. So the majority of them were either going into the surgery or using the phone or even getting someone else to book their appointments. And 79% said that it was difficult to get a GP appointment, and only 12% had ever used the 111 system. So one participant had talked about they'd come out from a long prison sentence and they said, well, everything has changed. First of all, things are more digital. And second of all, you know, appointments for this particular person weren't being taken over the phone anymore, and they commented that they're useless with technology and they were really struggling. So that's one kind of key thing that we need to think about. And then the other area was around this idea of emotionally coping. So we've got these kind of multiple overlapping needs of, you know, so although the study was about physical health, clearly the link to the emotional health was there, linked to substance misuse, issues around everyday coping, bereavement, worries around transitions. So, for example, from approved premises into other into other housing, and also issues around lack of self-esteem and confidence related to physical health, and, you know, their teeth and their appearance, etc. More positively, there was this emerging theme from the men themselves. You know, this wasn't something we asked them about. They were telling us what we saw as kind of a self-help theme, where they were taking their own kind of independent steps, literally steps. So kind of daily regimes of exercising, walking, taking accountability for their own health, you know, looking at pursuits low cost generally, things like meditation, boxing, looking at their own nutrition, to try and help kind of keep themselves on track, to keep them focused, to keep them busy, but also highlighted challenges around accessing these facilities, for example, gym facilities, in terms of cost, in terms of their neurodiversity, again, you know, low cost food, healthy foods, and also where their physical health is affecting their ability to engage in kind of healthy lifestyles. So the third theme was about relationships with health and probation, and I was actually quite surprised, pleasantly surprised, that generally relationships described with these participants, and remember, they said we were talking with the engaged participants, the ones that do come into the probation office, and they were you know, positive in terms of their relationships with both probation officers and health professionals. So 83% of the participants said their probation officers were aware of some or all of their health issues. Where, you know, they were less positive were, again, these frustrations around accessing systems, not just the professional systems, but sorry, the GP systems, but more broadly health and justice systems. And the agendas were set in terms of what they had to discuss, and actually, you know, they wanted to talk about their physical health. They recognized that those were key issues for them, and again, what we did see linked to some of the earlier work that I'd done the previous year was around trust in professionals. So this idea of, you know, bad experiences, perhaps through reception staff or being able to make appointments, that kind of had a knock-on effect. And then the fourth theme, and I know that I'm running out of time here, is around, well, what could we do? What can we do differently? And, you know, we did ask the men on probation, what would they like to see? And as you could expect, you know, they're all individuals and they all had a range of ideas, but these two kind of key sub-themes came up, which is certainly strong enough to highlight. So the first was the introduction of drop-in centres, and, you know, Steph mentioned one-stop shop, and certainly that was repeatedly mentioned by the men on probation. They would like to go somewhere where they could drop in, what's flexible, they can get a range of support related to their health and other needs as well. And, you know, I know that, you know, there are pilots and things, you know, looking at these sorts of arrangements. And similarly, we did talk about, you know, health coming into probation and whether that's been helpful, and that's something that we think is worth exploring further. And then the other and the final kind of sub-theme was this idea of key or support workers, and the benefits within the approved premises were certainly being felt in terms of, again, you know, Helen mentioned the importance of advocacy, having someone to advocate for them in terms of, you know, getting mental health support, you know, securing appointments, securing, you know, treatment, etc., following up on waiting lists, having that advocacy, you know, is certainly something that was coming out as a strong sub-theme. So, just as, as my final slide, I guess I have been reflecting on all of these things linked into some wider research that I'm looking at around social inclusion and social isolation. And there isn't time to go into this today, but happy to speak to anyone who wants to reach out to me here at Swansea University to talk about the work that we're doing, and to think more broadly, I guess, around inclusion health populations, to think about our community facilities, such as the work that I did in warm hubs, and how we can use those facilities, look at broader issues such as food insecurity, etc., in order to support kind of a healthier, happier population of people on probation. So thank you.
Brilliant. Thank you so much, Ella, for sharing all of that. It's really, really important research and really interesting as well. So thank you. And we will move on shortly now to then my final presentation, just to give an introduction to some work that's happening now around continuity of primary care. I did just want to mention, and I can see in the chat already, a few colleagues from HMPPS Health and Justice have been commenting, but just to sort of recognise the partnership that we've had with them and sort of the opportunities around health and justice that are coming out of this since the new role was formed about, I believe, 18 months ago. And thinking about how, so I know Natalie Paul, I think she's on the call today, is leading on this with Peter and Sadie within the different regions, and thinking about how we've worked alongside Public Health Wales, the different health boards and health and justice to really try and get this collaborative multi-agency approach. They've been able to lead, and I know Peter's put in the chat about some really interesting pilots and different areas of work, and I'm thinking of those innovations and opportunities that can be taken forwards around justice and health. So I think, as everyone said so far, quite optimistic about how it's going and the opportunities that are rising, and really sort of the increase in focus and momentum. And something that struck me through my work so far is the amount of dedication and passion that so many people have about the criminal justice population, trying to improve the health, recognising the public health need and the importance of supporting people who've come from all different backgrounds in life to help meet their best health needs and support from that. So I'll move on now to just this overview. So I don't think I introduced myself at the beginning. So I'm a specialty registrar in public health, working with the primary care division in Public Health Wales. And I've been looking at criminal justice and thinking about different opportunities within primary care of how we can support and move forwards to improve health. So in this session, I'm just going to quickly touch on continuity. I know it's been mentioned many times already today. Introduce what we're proposing for an all Wales guidance around continuity of care and best practice, and some of the themes that will be covered, and then raise either today, if there's any opportunity for discussion or feedback, or over the next few weeks we will be sharing more information about how different partners can get involved, because we really want this to be a co-produced piece of work and linking in with many different partners. At the end of the day, we want this to be something that works for everyone, doesn't add additional burden, but actually create something useful that can be used in Wales. So if I can go to the next slide. So just thinking overall about the vision, I know again we've spoken many different times over the course of today, thinking about what we want to see, and thinking from a primary care perspective as well. So what we want is equitable opportunities for people who are within the justice populations to be able to achieve their best health outcomes. We want everyone to be able to live the healthiest lives they possibly can, and people in criminal justice at the more vulnerable end of the spectrum should be able to be supported through the services that are available to achieve that. So just as a very high level overview, and just thinking about in terms of continuity of care, and this is, as you can see, very broad and high level, but in terms of healthcare settings, we've heard from colleagues in HMP Park today around prison healthcare, and we know that there's lots of services within the prison setting to support people's health needs, and lots of primary care support and intervention. Then in the community, we know we've got our general practice, our pharmacies, dentists and opticians. People, all of us in the community will self-refer to those populations, to those resources and access healthcare through that route. But they don't quite link up, and they are different healthcare services. So then that means that when people move between the two, then there are some issues around continuity and making sure that information is shared, that people can continue to receive the services that they were in the other setting. Thank you. So part of the work that I've done, I have looked at some of the health needs assessments that have been completed previously across Wales. So I know it's been mentioned that there's been some in approved premises, in probation, in all the prisons across Wales, and then some other recommendations, and such as the Senate review and other things have all created lots of recommendations about how can we improve the health needs for people in contact with justice. And I looked at whether there are any common themes across these that then we could look at an all Wales level from a primary care perspective. And one of them was around the continuity of care between the different transition in the community and other secure environments. So if we go to the next slide, it will just reflect as well that I've liaised with lots of stakeholders, and thank you everyone on the call today who's spoken to me around this. But continuity of care again came out as an issue, and we've heard from Ella and Natasha and Ree and other people around actually continuity really is an area that's important to people to maintain that consistency as they go to different parts of the system and get the best health outcomes that they can. So I've identified continuity as one of the 4 key areas of focus for my work whilst I'm with the primary care division. You'll see here there's also around increasing awareness, and thank you so much for so many people being on the call today to start to continue to raise awareness about health and justice and how important it is. And also, it's been mentioned already, long-term conditions, thinking about physical health needs and prevention and health improvement, thinking about how we can capture people early, make sure that their health needs are being met, so then they can achieve their best health outcomes in the future. And mental health and substance misuse are common themes running throughout all of these, but I've kept them separate as not one of my priority areas because there's a lot of work going on already within those 2 spaces. And as reflected, there's been less focus on long-term conditions and prevention within this population so far. So taking forward the theme of continuity, then I'm developing with lots of hopefully with lots of colleagues and with co-production with many of you on the call today around an all Wales guidance for transition, thinking about moving between primary care in different settings. And intentionally, this isn't a discharge guidance, so it's not just thinking about from prison to community, it's about all the different transitions that can happen and thinking if there's any different opportunities that we can look at to then support that from an all Wales level, learning from best practice, learning from each other to really then promote and support people to meet their health needs within the environment that we have at the moment. So high level different themes will include around communication and partnership working, and that's why I've mentioned it's so important that all partners are involved in this and make sure that it's something that works for different people within the system, and building on stuff that's already working and excellent pockets of success. Thinking about different record sharing opportunities, recognising the challenges with IT systems, for example, not communicating within the NHS and between different primary care settings. Thinking about the discharge summaries, and part of this is around raising awareness of, for example, prison healthcare and the needs of people on probation, and thinking about how we can communicate that to the wider primary care in the community setting who may not have that much contact or experience with people in contact with criminal justice and may not understand some of the unique things that may affect people and the other barriers that they face. And rationale about, for example, within prison, some medications can't be prescribed, but in the community, the primary care teams may not understand why that's the case, and just trying to spread that awareness and communication between the two. And then around early planning, making sure that we can optimise to the best that we can around making sure that there are plans in place. We know that lots of work's gone around us already, so it'll be around sort of learning from each other, seeing if there are any shared opportunities, and recognising the challenges faced with justice and the movement within the system. Medications came up as another issue around having enough medication on, for example, discharge from prison or when you move to a different area, making sure that there's that continuity of prescription to make sure that people don't have a gap in that care. And then prevention and early intervention. And again, this will be a focus thinking about how we can communicate if somebody's due screening test and then they've moved between setting. Have they had all their immunisations? Are they up to date? Smoking cessation, do they need any extra support with that? For example, if they smoked before they entered prison, even though prisons are smoke-free environments, is there opportunity there for when they transition and back into the community, do they need any extra support? And it's all about trying to add that extra layer of support, or thinking about how we can learn together just to add a bit more consistency and support continuity, because it's become such an emerging theme over the past. So I'll just sort of pose this question to you. It's not something you necessarily have to answer right now, but just thinking about what the ideal pathway for continuity would look like from your perspective, and everyone on the call will have a different perspective and be working in a different area. So if there's any ideas about what a good pathway would look like for continuity, thinking about if there's any key aspects, any key populations such as women in justice. We know there's been some really good work going on about pathways and transitioning from English estate back into Wales, different areas, just trying to make sure that we capture the whole picture going forwards. So thank you very much for listening to that today. In terms of the continuity work, then we will be socialising some more work over the next few weeks, trying to gather as much feedback as possible and really welcome any ideas or thoughts around that so that we can all work together. And I know I'm linking in closely with Natalie Paul from Health and Justice to really make sure that we're all working together on this. And I'd just like to again extend thanks to all our speakers here today as well, and I'd like to open up for any questions, comments, feedback, anything that anybody would like to share today. If you want to pop your hand up if you have anything, or if there's anything you want to put in the chat as well, then more than happy for, I think all our speakers are still here, so if anyone has any questions, then please feel free to share. Natalie? Sorry, Natalie, you're on mute.
Sorry, schoolboy error. Yes, so thank you for the presentations today, really interesting. So I'm Natalie Poole, the Health and Justice Partnership Manager for the Probation Service in Wales, and as been mentioned on the call, where our roles are around improving partnerships across the systems, including the continuity of care, improving pathways into health and treatment, reducing health inequalities and reducing reoffending. So we've been doing a lot of work with health partners, utilising the emerging data and evidence, and really informing and advocating for new ways of delivering services. And I know Ella mentioned a few suggestions earlier. So it's really around kind of removing those barriers and navigating those complex systems. Recognising, you know, the mistrust and stigma that's been raised. But I just wanted to just add as well that another key role for us is around improving probation practice. So ensuring health is kind of universally recognised as a pathway out of offending. So that means kind of ensuring the probation practitioners are fully equipped with having those health conversations, as well as how we're recording the data in order for us to kind of work with partners more you know, effectively. But just to say, really, I just share the optimism shared today and the importance really of working across. I think Helen opened the presentations with around working across those systems towards shared outcomes, and it's something that, yeah, we completely support. I'm hoping our role within the probation service really kind of improves the capability and capacity of the probation service to be around the table and engage in those health conversations. So that's it from me.
Brilliant, thank you very much, Natalie. And I can see Joanne, you've got your hand up as well.
Hello everyone, I'm Joanne. I'm a sexual health outreach nurse for Swansea Bay Health Board. I just wanted to jump on and thank everyone, all the presenters. Echoing what Natalie has just commented really about, you know, health as this pathway, you know, to a better situation for people. We talked about men today. I know it's men's only prisons throughout Wales, but I just wanted to mention thinking about, you know, the wider picture, their families and spouses. You know, from, obviously I work in sexual health, and contraception is something that we provide. So, you know, we need to think about that as well with regards to long-term partners, if they need contraception. Obviously, if, you know, an unplanned pregnancy may have detrimental effects, depending, you know, at the point in time, and like we spoke about the ACEs and things like that. So just wanted to put that out there as well, to think about, you know, the family health, not just the individual. Thank you.
Great, thank you, Joanne. And yeah, you've raised a really important point, and I know it was raised earlier in some of the talks as well about the impact it has on the families. I think it was Helen said, was it 300,000 children are affected by imprisonment, so that's a huge number. I know it's across the UK, but just thinking about the wider impact it has, and then the opportunities that we potentially have to influence that through the work. Does anyone else have any thoughts or anything they wanted to share at this point? Any good practice or examples that they've taken forward that they think would be useful to share within this forum? Matt?
Hi Penny, thanks for setting this up. It's been a really good opportunity for all of us to network and hear a bit about some of the work that's going on. But actually, that really brings me to a thought really. There's so much going on in this space, and there's so many people working in this space. So has anybody got any ideas about the best way to share any of our findings, our activities, so that we do learn from each other and we don't sort of repeat something that's been done elsewhere? And by example of that, Peter, and other colleagues within HMPPS and I undertook a needs assessment of people who are in the approved premises in Wales. Copies of that have gone to HMPPS and each of the health boards, but I'm not sure whether it's sort of trickled down to everybody actually working within this area. So what's the best way for us to share things like needs assessments and our activity?
Yeah, thank you, Matt. And I'm not sure if anyone on this call has any answers at the moment. One thing that I'm aware of, and I can see Steph just popped it in the chat now. So there is a Health and Justice UK community of practice, which the Wales one is currently sort of just in its infancy and just being established at the moment. But on there there's an opportunity for all of us to register, and then we can be kept in the loop of what's happening in Wales. So it's not hosted by Public Health Wales or us, it's the Health and Justice UK system, but there's a GP in Swansea who works in prison healthcare who is sort of coordinating and leading on that. So that might be one of the best places to then try and bring everyone together and have that information going forwards. Were there any other comments or feedback that anybody had at this stage? So all I would like to echo again is to say thank you so much to our presenters here today and for everybody taking the time to come onto this call today, and hopefully some of you as well who weren't able to make it will be able to catch up to this recording online. So if you do have any other comments or feedback that you want to make after this session, then please feel free to get in contact, and I can see lots of people have put their contact details as well in the chat, so that's brilliant. So thank you very much everybody. We will be posting just a short evaluation link as well. It'll be on the Microsoft Forms, so if you do have a couple of minutes just to fill that out, that'll be really good for the future sessions. And this does form part of a wider health inclusion sort of series of different webinars as well. So there was one a couple of weeks ago around general health inclusion and thinking about vulnerable and marginalised groups, and there will be a few more specific ones coming up around, I believe, sexual health and a few other areas as well. So please, if you want to be involved with that, please keep an eye out for that, and then we will take that forwards in the future. So thank you everybody for your time today. We'll get a couple of minutes back on your day, and anything at all, then please be in contact and let us know. So thank you again, and diolch, have a good day.
Cheers, thank you, bye.